Well, it's been a wonderful AUA. We're winding down. This is one of our last ones. But Dr. Siddiqui, we've been trying to get you on for a couple of years at this point, and we're happy to finally track you down. So I know Dr. Siddiqui very well when I was in medical school, but basically Harvard, Mass Gen, NIH, now kept him in Baltimore, and now University of Maryland, where he's doing awesome things, head of robotics there, head of oncology there. And so we're glad to have him. He's done some really cool things. We had so many things we could talk about, but there's one that was more recent. So tell us about your last and latest and biggest.
All right, thanks, David. Yeah, no, I mean, it's I'm glad this came together, and like you said, I've been wanting to do this with you for a while now, so yeah. I'm really glad it lined up to this time around. So it's been great. Yeah, no, I mean, I think in terms of latest and greatest, I think the thing that I've been most excited about right now is work in quality, and this is a growing area, and so it's been an interesting area. It's been a new area to me too, actually, and so in particular, I've gotten involved with the American College of Surgeons, and within American College of Surgeons, there's this structure called the Commission on Cancer. So Commission on Cancer is an accrediting body. Many hospitals throughout the country are part of this infrastructure, and about 70% of cancer patients that are treated in the United States actually get their care at COC centers.
I see.
And part of how all this works is a lot. I know actually because you did a lot of research with me. NCDB, the database. Yeah, sure. That database infrastructure is through COC.
I see.
And so there's a whole kind of capture system to look at patient outcomes, and within COC there are standards of care that are set, ideal goals. So when we talk about quality, it's really interesting because you can have different levels of quality. You can have quality that is minimum quality. Below this level of quality of care delivery, you are not performing good medicine.
Right. But I'm sure there's some gray area and
and certainly but then actually there's another version of it, and the words get kind of convoluted, but it's desirable top quality, right? That's also a form of quality. What is the best version of care?
Right.
And below that, it's not malpractice.
Right.
It's not even bad.
Right.
It's just not the best.
Right.
And so COC actually sets these measures as kind of desirable. There's guidelines. Guidelines often go for minimum standards, but COC also has these things called measures. And measures go for that desirable level of care.
I see.
Right, what we should be aiming for, and then as part of accreditation institutions, they review how they're doing. Now they don't have to meet all their credit, but the infrastructure allows to actually constantly record, review, and seek improvement in these things. And so I got involved with a lot of people, many of whom came through the assistance of the AUA Quality Office.
Okay.
And so it's been a nice collaborative venture in many ways to review the GU quality measures within this portfolio of quality measures that the COC has. COC has 30 quality measures, of which 3 are GU measures: 1 kidney, 1 prostate, 1 bladder. So this it was a 2-year process. This summer they went live. And the 3 quality measures are, so you can a little drum roll if you like, but, prostate. Prostate. For low risk prostate cancer, you should be doing active surveillance.
Right.
Yeah. Now you don't have to be 100%, but in general, and there are exceptions. There are scenarios where it makes sense, but most of the time, low risk prostate cancer should be getting active surveillance.
And so when you look at these measures, they're trying to figure out if this is on average being done, or
so you get a number. So each institution actually, the way that things are set up, the way the NCDB is set up, patient data is reported into a central database. However, you can pull, individual centers can pull their data, so they can see that 65% of the patients that they had that low risk prostate cancer were put on active surveillance, or 20%, or 99%. Right. And so, and through this methodology, we can actually come up with the mean number. So it turns out 56% of patients who had low risk prostate cancer active surveillance were put on active surveillance. in 2020. There's a lag, so it's I think 2022.
Okay.
And so you can see where your center falls, and you can see, and we did some analysis on this, and there were some centers that had 10%,
Right.
and there were some centers that had 95%.
Right.
Right.
So even though it doesn't give you a patient-specific reason why they may have or may have not been,
Yeah.
but you see a general.
You get a sense, and you probably, if you're a 10%er,
Right.
like chances are 90% of your patients don't qualify for exemption on
Right.
a good reason for having had like surgery or
Right.
radiation or
Right.
whatever it is that
Absolutely.
they had done. Yeah.
Absolutely.
For bladder, the quality measure is that for patients with low-grade bladder cancer who had TURBT, that they should have had a intravesical chemotherapy.
How did you choose that
post-op.
one?
It's a level 1 evidence. It's guideline recommended, and it's level 1 evidence that the recurrence rate goes down by about 30%
Right.
when you do that. And so it's in multiple guidelines. It's in NCCN, it's in AUA, and so it's something that we really should be doing. This is a striking one because this is in the guidelines. It's level 1 evidence. Other things are not even level 1. There's actually very few measures that are level 1 evidence.
Right.
It's hard to get that kind of level,
Sure.
right? Randomized clinical data
Right. Sometimes
showing a
you
benefit.
don't need to do a randomized
Yeah,
trial.
exactly. The whole thing. Yeah, exactly. And so this one is 23%. So it's one of the lowest performing measures in the entire portfolio, not just a U measure, and yet it's one of the very few that is recommended both by guideline statements and level 1 evidence. And so this opens up a whole new other avenue, which is quality improvement work.
Right. Is this supposed to try to get institutions and hospitals to, amend or change how they change practice?
Yeah, it gives us like things to work on.
Right.
Right? It gives us something to do.
It's almost like a best practice
Yeah.
that is being used to further better practice.
Yeah, exactly. So this is the measure.
Right.
And you need to, it's like one of these concepts of like quality improvement work that until you measure something, you probably won't be able to improve it.
Right.
Right? Because you don't even know how you're doing.
Right.
And so
In a way, looking at a hospital, doing that thing is the measure.
Yeah.
Interesting.
That's very much so. Yeah. And the cool thing about this scenario is that there's a whole infrastructure. There's cancer tumor registrars.
Right.
They're actually called something different now. They're called oncologic drug specialists. They changed their name recently, but
Okay.
in case you were curious. Yeah.
What's the kidney one?
Kidney one is that for kidney cancers that are treated by surgery, which are clinical T1A, so less than 4 centimeters, that partial nephrectomy is preferentially used over radical nephrectomy.
That's an interesting one because you can have different locations for the tumor and
Yeah. And so that's what it goes to. 100% is not the goal.
Right.
But if you're getting 5%,
Right. It's more
partial,
of a trend, right? I get that.
It's more of a general, and you kind of see what general people are accomplishing, and then you see if you are within error bars of that range. And actually, the performance rate's about 75% nationally.
Okay.
And
which
so,
is pretty good, right?
That's pretty good. And I don't think that's something that necessarily has to shift. But if your center is like 10%, then maybe you should look at like why you're doing so many radicals rather than partials.
Right.
Yeah.
Is there going to be more of these guidelines and practice?
The process is a living process. So what happens is that the guidelines are reviewed. The goal is not to have more. I think out of this portfolio of 30, three will always be GU because it's 10 disease areas with 3 per disease area. That's the setup. But the idea is that these quality measures, as compliance gets better and better or stabilizes, they may not be useful as quality they're specifically quality measures because the whole point is that these are things that we want to improve on.
Right.
Quality improvement measures is technically what they are. And so once the quality improvement aspect of the measure kind of dissipates and it's not that much useful for the quality improvement aspect of things, they'll probably be replaced. That's
right. If everyone starts to follow these and the trends start to go up and it's become not as useful anymore, it'll switch out.
Yeah.
That's really cool.
Yeah.
That's really cool. Have you found that when you present these data that there is a change Or we're not there yet?
This stuff is new.
It's new.
It's new.
So that's
this
the
is
goal,
like,
though.
That's the goal. I mean, my current work, and I think like it's not just mine. It's like there's a whole team of people involved, and like we're all coming together. Again, this is actually highly collaborative with AUA Quality Committee at this point. Is that we want to now hone in, especially on that bladder measure, and come up with methods to turn this into a national initiative.
Yeah.
And see if we can get those numbers better.
Yeah, it seems, you have something to measure, you have something to compare to every other place, and it seems very straightforward.
Yeah, so we'll see how that goes, but I think that's it's been a hot area. It's been really interesting. I think a lot of people are excited about it.
It's really cool. Any other type of quality initiatives that you're doing, that you're in the middle of doing?
Yes. So the other thing that's actually I think really active right now is operative standards. Is another kind of whole avenue of things, and so this is an ongoing initiative that's been going on also through American College of Surgeons. This was actually initially in collaboration with Alliance Clinical Trials Consortia.
Okay.
And back when this thing was founded, which has actually now been, I think, almost 10 years, when there was a clinical trial and it involved surgery. So let's say the clinical trial to test neoadjuvant chemotherapy for bladder cancer in a patient who's going to get cystectomy. The trial design would often lay out what should be the neoadjuvant chemo, and like the randomization is in the chemo.
Right.
Some chemo plus or minus immunotherapy.
Sure.
Followed by cystectomy. There'd be a lot of guidelines on how the chemo is given, what's compliant, what's not compliant, like how that all works out. And then they would say plus cystectomy. But there wouldn't be actually a good measure of what a good cystectomy was.
You've been working on this for a long time. I remember.
Yeah.
Yep. Yeah. So.
Yeah.
So what do you?
And so this whole initiative is actually to give guidelines on like what good surgery is.
Right.
And you come up with these like key elements of like what good surgery, and it's a tricky thing to do because it's a lot of expert opinion. There's some evidence, but often it's not a lot of evidence. It's actually just getting together people who are respected and experienced and thoughtful, get all the evidence you can, and just come up with a list and validate that list.
I think that the surgery world has been waiting for something like that for a long time.
Yeah. So it's good. So bladder cancer's out, and we're actually like now working on prostate cancer.
Awesome.
So that's been the most active.
Well,
thing.
then we'll have to have you again.
Yeah.
It's time to talk about that.
Would love to be back.
Thank you so much for joining us.
Yeah.
It's very
Thank
good.
you. It's been great.